Hello, thank you for the introduction and thank you for the organizer for this opportunity. So let's get started. All right, so percutaneous thermal ablation is a process where interventional radiologists use heat or cold to destroy cancerous tissue in a target organ. It involves advancing a special type of needle into a tumor with the assistance of imaging. Imaging is utilized to accomplish several steps. So the first one would be tumor localization. This could be either on the same day or pre-procedural, meaning a couple of days before or even a month. The next one is needle positioning. This typically requires between 5 and 15 scans. And lastly, post-procedural assessment. Now, there are a few challenges with this technique. Here on the left, we see an enhancing, meaning live or living part of the tumor, which requires another ablation cycle, in this case, another repositioning of the needle. Another challenge is damage to critical structures. So in this case, we see a complete coverage of the tumor, but also thickening of the diaphragm, which means that some damage has occurred. Other examples of critical structures that are at risk are blood vessels or nerves, which make interventional radiologists cautious to the amount of energy that they apply or deposit. So all this leads to higher than desired recurrence rates. This is a meta-analysis of 25 papers where we focused on local liver tumors. So for radiofrequency ablation in the bottom, you can see that there is a recurrence rate of about 20%, meaning that every fifth patient on average will require to come back to the hospital. And this comes at huge logistical costs to the health system, financial costs, and of course, pain and psychological hardship to the patients. Now, later generation microwave ablation improves things, but you can still see a recurrence rate of about 10%, meaning that every 10th patient or so will require additional treatment. So real-time thermometry has the potential to help lower the recurrence rates, sorry, by enabling currently blinded interventional radiologists to visualize temperature distribution during the ablation. CT is a prime candidate for this since it is already being utilized, for most of the ablation procedures. Now, the relation between Hounsfield unit and temperature changes have been studied since the late 70s. And they stem from the volumetric expansion equation. However, Hounsfield units are not such a good sensor for temperature changes because of two things. First of all, as you can see, this approximation is only valid for very small delta t's or for small delta t's, which in this case, delta t is not very small. And second of all, there is a hidden assumption here that the CT numbers or Hounsfield unit depend only on density changes and not on composition changes as well. So all this leads to large discrepancies between different studies, up to 50%, even if we disregard the bottom one. So we still have a 50% variation between results. And this is expressed in the slope or by the expansion coefficient alpha. So enter spectral CT. So spectral CT uses information from two or more distinct energy spectra to acquire material quantifications. So there are different available technologies that are already being used clinically for this purpose. In this study, we utilized the spectral detector or dual layer technology. Clinically available spectral results include the virtual monoenergetic images, iodine maps, virtual non-contrast images, and effective atomic number maps. In last year's SPIE, we presented work where we showed very accurate physical density assessments that we generated from clinically available spectral results. So here in this plot, you could see the error in quantification compared to the nominal error provided by the phantom manufacturer. And except the lung inserts, which we can also explain, you can see that all of our measurements are within the manufacturer's variability, meaning that we're as good as the ruler that we have at our disposal. In this year's SPAU, we presented, my colleague Leening presented work on validating these results by performing non-invasive mass measurements of this steak. And here are the results. So the lines represent weight measurements before and after the scan, and the dotted line in the middle is their average. And as you can see, for a 350-gram steak, we're about 1 gram away, which is very nice. And this enabled us to take the next step and to use the physical density quantifications for thermometry. Okay, so we used the same steak and inserted into it optical fiber temperature sensors, and we then heated the steak using preheated water. These are images of the physical density map at 22C and at 50C, and as expected, you could see a decrease in physical density. These are the analysis results across a temperature change range of a bit higher than 25C. You can see that the intercept that we got is exactly 1. And this is, again, a fitted intercept and a very high correlation. However, you can also see that the noise is not very dependent on dose. And this means that it's likely driven by local tissue heterogeneities, and in fact prevents us from performing temperature sensitivity calculations. So we decided to take one step back and focus on dedicated phantoms in order to understand the potential and sensitivity of this technique. So we started our work, obviously, with a literature survey, and we came across this paper from the NIH, from the group of Brad Wood, where they developed thermochromatic phantoms that changed their color based on the peak temperature that they saw. More relevant to our work is the fact that the mass density, thermal conductivity, and thermal diffusivity of the phantoms were measured and found to be in agreement with values reported for human tissue. What we did next is start from their recipe for these phantoms and modified it so that these phantoms would also have the attenuation of human liver. So you can see the red curve is where we started from. There is about 15 Hounsfield unit difference. And after a couple of iterations, we achieved a phantom attenuation that is within 4 Hounsfield unit to that of human liver tissue across the entire X-ray spectrum. So this is all very good, but we wanted to make sure that these phantoms still behave thermally as liver tissue. So here you can see one of our phantoms and my finger for scale. We used a thermal property analyzer to characterize the phantoms. A similar approach was used by Lopresto et al. To measure ex vivo liver tissue. And these are their results, and these are our results on top of that. So we can conclude that our phantoms behave as liver tissue, both thermally and attenuation-wise. Okay, so this is our experimental setup for the thermometry experiment. On the left, you can see a heater that we use to elevate water temperatures above the lethal temperature of 60C. We measure the water temperature using 2 thermocouples, one next to the heater and one across it. We then used in our phantoms, we embedded 2 optical fibers, one with a 4 temperature sensors using Bragg interferometers, and another one that we used for reference. Of course, all this was done under CT, scanning at the shown dose levels, iterating between them every 30 seconds or so. This is one example of a scan, and you can see the straight line is the FBG fiber that holds 4 sensors, and the curved line is the reference fiber. So we had 2 purposes or 2 goals in our experiment, but before we go into that, let's look at the temperature curve plot. So the orange and blue or light blue lines are the thermocouples that measure the water temperature. You could see the point where we added water. You could see the point where we started heating. That's at about 18 minutes after the experiment. And you can also see the steps where we added ice in order to accelerate cooling. The neon or brighter colors are the FBG sensors, and the black curve is the reference fiber. Going back to our 2 goals, so we performed linearity tests looking at the slope variations between the different FBGs and between the different scan and recon parameters. And we evaluated how good or how linear the results are using Pearson's R value. We also looked at temperature sensitivity, where we used error propagation for both the cooling and heating curves, where we used the first and second time points shown in gray for the heating curve, and the second and third time points for the cooling curve. And of course, we compared all our results between the cooling and heating curves. So these are the results for the linearity test. You can see that things are quite linear. This is an example for a specific reconstruction parameter set at all different dose levels. These are the results of the slopes. So let's walk slowly through this. This is separated into 5 groups according to dose, so categorically. The y-axis is the slope, and for every dose group, you have 4 blue lines, which are the 4 FBGs during cooling, and then 4 red points, or a bunch of sequential 4 points in red, which are the 4 FBGs during heating. And along each line, we have the different reconstruction parameter settings. But as you can see, it doesn't really matter which is which. We see a very nice alignment of all the parameters across all those levels. And there is less than a 4% variation between the different parameters, doses, cooling, heating, etc. These are the correlation coefficients from these linear assessments. As you can see, almost all of the results are above 0.99, and when we get to clinical dose levels of about 10 milligray, we're above 0.995. So all this is very nice, and we concluded that we have a high correlation between the measured data and the approximation-free model. Going to the temperature sensitivity, this is a heat map separated into 3 major columns by slice width. So we have 2, 3, and 5 millimeter slice width, which within each column we have the 4 FBGs, and then rows are separated into groups of dose, and within each dose we have the denoising level between 0 to 6. Here you can see the temperature sensitivity map for the heating curve. You can see that things are a bit better, meaning greener. And we can explain this by the fact that the first time point used for measuring the temperature sensitivity on the heating curve is actually without the water in the buckets. So there is less attenuation, less noise, and thus better sensitivity. Converting to a binary representation using 3C as a threshold, we see that we can identify a scenario in which we fulfill the clinical requirement of 2 to 3C temperature sensitivity at a clinical radiation dose level. So summarizing our results, before that, in the movie that you see playing while I talk is a temperature change map of the phantom, a coronal slice in the middle of the phantom. So as I started, we utilized our physical density model, which was validated on by whole organ non-invasive mass measurements, and we demonstrated the expected density temperature relationship on tissue. We then developed spectral thermal liver mimicking phantoms that have both matched X-ray attenuation of liver and maintain the thermal properties of liver. We then demonstrated very high correlations with the expected thermal expansion model and demonstrated below 3 sensitivity at a clinical dose level, which is the first as far as we know. Our next step would be to address metal artifacts, which could bias the physical density assessments and propagate into the temperature assessments. We also want to develop a composition change awareness map to help interventional radiologists be aware that something has changed within the tissue. Having these two, we will proceed to perform both ex vivo and in vivo studies in a clinical setting. That is my talk. Thank you for your attention.
Thank you. This paper is open for questions. So Nadav, I have one. So for the purpose of liver ablation, you can also use superfine needle thermocouples and FDG as you used. Could you comment on, because that one can give you a better temporal resolution, truly real-time monitoring without using any radiation. Could you comment on the benefit of using this?
So using what for the temperature?
Superfine needle temperature monitoring, like a thermocouple.
So my first comment on that would be a single point measurement, where we intend to provide a temperature change map overlay that the doctor could see the entire region. I wouldn't say the entire body, but the entire region proximal to the treatment zone. I think that's the major difference. The other difference is that the patient is already there. The CT is already being utilized as part of its current workflow. So there is an advantage in utilizing it more, even further, with existing technology to obtain these temperature maps without introducing additional equipment, invasiveness into the room.
Thank you. Please.
Hello. You mentioned you're using a photon counting CT.
Not for this project. In this project, we use the dual layer spectral detector CT.
Okay. Would it help in any way to have multiple energy bins or multiple energy thresholds?
So it depends on the spectral performance of the system. Our physical density work, which we presented in 2001, relied on clinically available spectral results. So it's the 70 kV VMI and the Z effective. These are the inputs for our physical density map. Given the image quality of these two inputs, I mean, that would depend on the final result. That's the only input. So if a photon counting CT or I don't know, next generation CT can provide more accurate Z effective and 70 kV VMIs, then that would benefit this work as well.
Okay, thank you.
So in practice, what do you think the spatial resolution is you would offer to the physician, and do you have to pull back the needle to take the CT, or you would keep the needle there and that's why you need the metal artifact reduction?
Yeah, so the idea is definitely to keep the metal there. I mean, this is the scenario we're imagining is a scan every 2 minutes or so while the needle is heating. So I mean, I need the needle there. As for your second, what was the first question? Sorry.
Spatial resolution, would you show like 1 millimeter voxels or 3 millimeter voxels, or?
So these results are not intended for diagnosis, right? They're an overlay that show the temperature distribution real time. So we actually think that there is a resolution budget we could eat into to improve the sensitivity. There is, I mean, it needs to be fast, it needs to be almost real time, but it can be a very aggressive total variation. I mean, we can lose some resolution without impacting the clinical usefulness of it.
Quick question. I noticed that the phantoms that you found were published in the Journal of Hyperthermia. And I was wondering if that was an application that you were thinking of for this in terms of, basically monitoring temperature during hyperthermia for radiation therapy.
I did not.
Oh, if no more questions, let's thank our speaker again.